I'll be presenting coexisting cataract and glaucoma, trabeculectomy, Phaco trabeculectomy or Phaco alone.
How many of you are doing a combined surgery here other than CK, sir? None of you. Only 2? 4. Okay. So now it is duty of yours to convince and then make them do the surgery. Yeah.
So, very good evening. Coexisting glaucoma and cataract. This is both these are age-related diseases and they often coexist. So, such patients often come to us and many a times we are at a dilemma to do with, to proceed with which procedure. So, we have to individualize the case. You have to stage the glaucoma as Sir has said. Always consider the glaucoma and consider the cataract. Whether the patient requires surgery, that's the first thing. And stage the glaucoma, what's the type of glaucoma, what target you want, the medication burden, and whether the patient is compliant, the status of the optic nerve, the visual field defects, and the cataract's impact on vision. Always consider the comorbidities, the age of the patient, and the affordability, and decide which procedure you want to go ahead with. So, this is a 76-year-old man with an NS3 cataract, hypertension, diabetes mellitus, CAD, and the patient has an IOP of 28 and 20 millimeters. So, he is a moderate glaucoma with a visual field defect threatening fixation, and he is already on 3 AGM. But he has all the comorbidities and cataract. So, glaucoma and cataract with all the comorbidities, 3 AGM and uncontrolled IOP. So, how to proceed? So, first we will discuss and then we will come back to this case. So, phacoemulsification alone is indicated usually in mild to moderate open angle glaucomas and angle closure glaucomas, which are well controlled with anti-glaucoma medications. And there is significant cataract affecting vision. These will result in the phaco will give you a faster visual recovery and there are fewer complications. Unlike trabeculectomy, it may cause a small sustained IOP reduction also when the lens is removed. But you may not get adequate control, especially in advanced cases. And once you have handled the conjunctiva, and especially if a scleral tunnel has been done, there will be conjunctival scarring, and future trabeculectomy may be difficult and the results may not be that good. If you are doing a trab alone, usually it is indicated in advanced glaucoma with minimal cataract where the target IOP is less than 12 millimeters and IOP is uncontrolled even with maximal medical treatment, or in spite of that the visual field is progressing. This is the best IOP lowering potential and it's still the gold standard, but it may accelerate cataract formation. Once you do a trab, the patient is likely to get a cataract at least after 2 years. And a phaco after a trab can jeopardize the function of the bleb. But when there is very uncontrolled IOP, it's always better to do a trab, that I will come to later. So, phaco trabeculectomy, that these two procedures are combined together in moderate to advanced glaucoma with coexistent significant cataract, and when the patient has a poor compliance or intolerance, and in elderly single-eyed patients where one procedure is preferred, one definitive procedure is preferred. So, it can address both the diseases simultaneously and it is convenient to the patient and it reduces the cost, risk of surgery, and multiple surgeries are avoided, and avoid the postoperative IOP spike which can be due to the retained visco or inflammation or steroid response. So, but technically this is more demanding with more intra and postoperative complications. There is higher inflammation, slower visual recovery, and there may be postoperative complications like hypotony, shallow AC, etc. And this phaco trabeculectomy is less effective in controlling IOP than trabeculectomy. So, in angle closure disease, the lens definitely has a causative role. So, when lens extraction is done, it can increase the outflow, it can reduce the IOP and improve the visual acuity. This is a meta-analysis of 11 RCTs which showed that phaco trab was superior than the other two surgeries in IOP control chamber depth, visual acuity, and adjunctive therapy. But TRAB is definitely superior than Phaco in IOP control, but it has more complications because most often we are doing it in a eye with a high IOP and we expect a very low target IOP. Now the latest alternative, that is the Phaco plus mix. It combines Phaco emulsification with mix. The modest IOP reduction with minimal complications and a rapid visual recovery. And mix usually targets the physiological outflow pathways rather than creating an external bleb. So the choice of mixed procedures are there. This is a classification of the procedures. I won't go into that. Usually, it is done in mild to moderate open angle glaucoma, pseudoexfoliation or pigmentary glaucoma. Elderly monocular patients where safety is more important than IOP drop, and patients desiring medication reduction and rapid recovery. And combine cataract and glaucoma surgery with target IOP less than 18, not when you are expecting a more reduction, like not suitable for advanced glaucoma with target IOP of less than 12. So when a moderate reduction is desired, you can opt for this. It has high safety level and there is angle anatomy is not that altered. You are directly visualizing it and going with the procedure, and it has got a shorter surgical time. It can be easily combined with cataract surgery because it can be done through the same clear corneal incision. It preserves the conjunctiva so you can do a future trabeculectomy, and it reduces the dependency on topical medications. So it is an excellent alternative, but it has only a modest IOP reduction. Maximum is 20 to 30%. And there is device cost and availability to be considered and limited long-term data beyond 5 to 7 years for some of the devices. Now another alternative, though expensive, but with a predictable aqueous outflow is express shunt, which can be combined with Phaco. It is placed, you make a scleral flap, so you create a bleb. You place the express shunt into the anterior chamber. It has an internal lumen of 50 to 200 microns. So this has a predictable outflow. So it provides an excellent middle ground between high IOP control of trabeculectomy and the safety of mix. And it is indicated usually in visually significant cataract and moderate to advanced POAG or PXFG, which requires a target IOP of around 15 millimeters. And here, patient who need better IOP predictability and fewer postoperative fluctuations, but it has to be affordable because it has a high cost. And conjunctival, those eyes with conjunctival scarring where TRAB is likely to fail, or eyes with thin sclera, uveitic glaucoma, etc., this may be a good alternative. It has a more standardized aqueous outflow, less postoperative inflammation. There is no iris manipulation unlike in trabeculectomy where you do a PI. Lower rate of hypotony, flat AC, etc., and has got an often faster visual recovery. And it can be safely combined with Phaco. But it has higher cost and it still forms a filtering bleb. So bleb related complications are possible, and comparable long-term IOP control to trabeculectomy. And it requires mitomycin C for best outcomes. So this is just a summary decision algorithm. Early glaucoma with a controlled IOP with 1 or 2 medications, you can go ahead with Phaco alone. That Phaco alone will produce some amount of IOP reduction, and you can continue with the 1 or 2 medications. And advanced glaucoma with minimal cataract, always better, or uncontrolled IOP. Then you can go ahead with TRAB first. Then when the patient develops a cataract, you can do it later but carefully. Significant cataract with uncontrolled glaucoma, go for phacotrabeculectomy, but always expect complications, do it safely. Mild to moderate glaucoma with cataract, it needs modest IOP drop. You can go ahead with Phaco and mix. I have not much of experience in mix. I think Sir or Dr. George can say something about combining Phaco and mix.
Thank you, Dr. Girija.